Today we'll be studying about lung mechanics and gas exchange. The first concept would be lung mechanics. In lung mechanics, our objective would be to study airway pressures and to understand the airway pressures relation with compliance and airway resistance. Right. So in airway pressures we have inspiratory airway pressure. Inspiratory airway pressure. And this has got two sort of versions. One is known as pressure peak, or you have heard this term peak pressure, and other is pressure plateau. Which the other name is plateau pressure. Whenever patient is on ventilator, these two terms are very frequently used, peak pressure and plateau pressure. So they are basically the component of inspiratory airway pressure. Now if we talk about ventilatory pressure or ventilation pressure, which is delivered by ventilator, so it can be divided into two parts. One is elastic pressure. This is that pressure which inflates lung and chest wall, right? The other is resistant pressure. Resistance pressure is that pressure which the tubings, the bronchi, bronchioles exert on the flow of the air. So there are two components of ventilatory pressure. One is elastic pressure, that is that pressure which pushes the lung and chest cavity outside, and one is resistance pressure which is given by the airway. Okay. So when can we have increase in ventilation pressure or ventilatory pressure? If your elastic pressure goes up or your resistance pressure goes up. So the airways are offering more resistance, so ventilator has to apply more pressure. If the elasticity of the lung is increasing, that means compliance is decreasing. Why? Because compliance is inversely proportional to elasticity. More elastic the lung is, the lesser compliant it is, right? And less elastic the lung is, the more compliant it is. Right? So to understand peak pressure and plateau pressure, so first of all, what is peak pressure? Peak pressure. It is that pressure which is applied by airways at the end of inspiration. The ventilator is applying some pressure in the airway. Air is moving into the lungs, into the alveoli. So at the end of inspiration, the maximum pressure which is there in the airway is known as peak pressure. Maximum pressure at the end of inspiration in the airway is peak pressure. And what is plateau pressure? Plateau pressure is at the end of inspiration, if you block the expiratory tube of ventilator, you block the expiratory circuit of ventilator at the end of inspiration, so the respiration ceases, but the pressure between the airway and alveoli, there is a gradient. So air continue to move, and after certain time there is a equalization of pressure in airway and alveoli. That is known as plateau pressure. So it becomes plateaued. There is no movement. We'll learn it with a graph. So this is proximal airway pressure this is your inspiratory limb. So as there is inspiration, ventilation is applying pressure into the airway. So airway pressure starts increasing. They go up, up, up. Here the maximum inspiration has taken place. Now you hold the tube. Suddenly the expiratory circuit, you hold it, or you stop the flow of air into the expiratory circuit. So what will happen? The flow ceases, but it falls, but there is a pressure gradient, and then it goes like this. So this is hold phase. Why there is a slope downwards? Because air is continuously traveling from a area of high pressure, that is airways, to the area of low pressure, that is alveoli. So there is a drop, and this is the plateau. And once you remove the obstruction on the expiratory circuit, there is a passive recoil of the lung which causes expiration. So this is expiration. So in the graph, this highest pressure, maximum pressure, is peak pressure, and this slope, when it becomes plateau, this is known as plateau pressure. So you will find this type of graph in your ventilatory monitor, where there will be an inspiratory limb, then there will be a dip, there will be a plateau, and then there will be an expiratory limb. So this completes the circuit of proximal airway pressures, right? You are not measuring expiratory pressures. We are focusing on inspiratory circuit. Okay. So there are two things. One is airway resistance, and other is compliance. They are the two variables which determine inspiratory pressures, right? Which determine inspiratory pressures. So how do we measure airway resistance? We cannot measure it directly. We have to apply some formula. So airway resistance is, there is a formula known as Q, pressure difference, delta P divided by airway resistance. Q is airflow. This is simple, that airflow is directly proportional to pressure difference. The higher the pressure difference between two areas, the faster the flow will be. And it is inversely proportional to resistance offered by the airways. So higher the resistance, the lesser the flow will be. So you can interchange the variables. Resistance is equal to difference in pressure by airflow. Okay. So how do you calculate difference in pressure? So we studied two pressures. Peak pressure minus plateau pressure is the difference of pressures. Okay. And Q is indirectly end is inspiratory flow. Flow rate can be calculated. So this is Q is directly related to end inspiratory flow. So if you know peak pressure, if you know plateau pressure, and if you know end inspiratory flow, these three variables can be judged from ventilator. You can definitely calculate resistance offered by the airways in that patient. Okay, it's a variable. So when can we have increased airway resistance? We can have increased airway resistance, say for example in anything which leads to bronchospasm will increase airway resistance. Suppose there is a mucus plug. there will be increased airway resistance. Suppose there is some extrinsic compression on airway, there will be increased airway resistance. Suppose patient has aspirated a foreign body, so there will be increased airway resistance. There is excessive secretions in a patient who is on ventilator, so that will offer airway resistance. So these are the causes in which you encounter increased airway resistance. So how do you go for compliance? So we had a formula in last lecture that compliance is equal to change in volume divided by change in pressure. Compliance is change in volume divided by change in pressure. So what is change in volume? It is end inspiratory volume minus end expiratory volume. Correct? Simple. End inspiratory volume minus end expiratory volume. What is end inspiratory volume minus end expiratory? It is tidal volume. This is tidal volume. So volume change is practically tidal volume. You know tidal volume in your ventilated patient, divided by end inspiratory pressure difference from end expiratory pressure. So you can calculate lung compliance with this formula. You know tidal volume, you know end inspiratory pressure, you know end expiratory pressure also, right? So you can calculate compliance. So two variables which you can calculate are airway resistance and compliance. We talked about peak pressure. Peak pressure is directly proportional to airway resistance and inversely related to compliance. And plateau pressure is only related to compliance. It is unrelated to airway resistance. So what can be judged from these two things? If you have only increase in peak pressure, suppose in your ventilatory patient you are standing and you see that my peak pressures are high. So what does it mean? That means, see, plateau pressure will change when compliance changes. So that means this part is not affected. That means compliance is not changing in that patient. So the only thing which is changing is airway resistance. So if only peak pressure is increasing and plateau pressure is relatively normal, that means your patient has some pathology which is causing increased airway resistance. So out of those 5, you have to search now, right? Suppose your peak pressure is increasing, your plateau pressure is also increasing. That means compliance has changed. To change plateau pressure, compliance needs to be changed. So if there is decrease in compliance, there will be increase in peak and plateau pressure. Got it? So when you have two variables, if one variable peak pressure is increasing, plateau pressure is normal, that means compliance of the lung is not changing. The only change is in airway resistance. So you have to search for the cause of airway resistance. But if peak pressure and plateau pressure both are increasing, that means that compliance is changing. So decreased compliance is there. You have to search for the cause of decreased compliance. So what can be the cause of decreased compliance? Decreased compliance. say you have gross ascites, gross abdominal distension. If you have gross abdominal distension, there will be difficulty in expansion of lungs, so compliance decreases, right? If you have gross pulmonary edema, your lung compliance will obviously decrease. You have pneumothorax, right? You have large pleural effusion. Or inadvertently you have placed your endotracheal tube in right main bronchus. Right main bronchus intubation. In all these conditions, there will be decreased compliance. So your peak and plateau pressure will increase in all these conditions. So suppose a patient has pneumonia, he develops sudden pneumothorax. So suddenly your peak pressures and plateau pressures will increase. Getting the point? So only change is decreased in compliance when both are increasing. Right? So this is basics of lung mechanics, wherein technically you need to understand peak pressure, you need to understand plateau pressure, you need to understand lung resistance, you need to understand compliance. So these are the 4 things which constitutes the basics of lung mechanics in a patient who is being mechanically ventilated. Now we come to gas exchange. This is bronchi, this is alveoli, this is your blood vessel, this is bronchial, that epithelium from where the gas exchange takes place. So PO2 in inspired air is 160 millimeters of mercury. PCO2 in inspired air is 0. This is the tension of air gases. PO2 in inspired air is 160, PCO2 is 0. At alveoli level, PO2 is 100. So this is denoted by P capital A O2, P alveolar O2. This is 100. Okay. And P capital A alveolar CO2 is 40. This is at the level of alveoli. This is mixed venous blood coming from body, mixed venous blood. This is pulmonary artery which is carrying the mixed venous blood towards your lungs. Here PV venous, PVO2 is 40 and PV, that is venous, CO2 is 46. These are all in millimeters of mercury. Here there is exchange of CO2 and O2, and O2 gets into equilibrium. P small a, this is arterial. Capital A is alveolar, small a is arterial. PaO2 is 100 and P arterial CO2 is 40. Right? Simple. O2 tension in inspired air is 160, CO2 tension in inspired air is 0. At alveolar level, the oxygen is at 100, CO2 is at 40. In mixed venous blood, oxygen is at 40, CO2 is at 46. In arterial blood, the tension of O2 is 100 and CO2 is 40. You have to remember two things. You don't have to remember the equations, they are difficult, but just to remember the concept. The first thing is alveolar ventilation equation. Alveolar ventilation equation. It technically is telling you something about tension of CO2 in arterial blood. Okay, so alveolar ventilation equation is technically talking about PaCO2. Okay, now this PaCO2 is inversely related to alveolar ventilation. From last lecture we know that what is alveolar ventilation. Alveolar ventilation was Vt minus dead space into respiratory rate. I hope you remember. Tidal volume minus the dead space volume into the respiratory rate was alveolar ventilation. So if the patient is breathing fast and deep, right, so the alveolar ventilation increases. If alveolar ventilation increases, your PaCO2 decreases. So anyone who is breathing heavily, or the depth of breathing or the rate of breathing is more, so indirectly the alveolar ventilation has increased, your PaCO2 will decrease. Now just imagine that the dead space increases, volume of dead space. There is some pathology because of which the dead space increases. If this dead space increases, the denominator goes down, okay, as compared to the previous one. If this goes down, PaCO2 increases. So whenever you have increase in dead space, right, your PaCO2 increases. The second equation is alveolar gas equation. It is technically telling you about tension of O2 in alveoli. Okay, tension of O2 in alveoli, P capital AO2. This is determined by either FiO2, the fraction of oxygen inspired in the inspiratory air. So more FiO2, your alveolar O2 goes up. Nothing difficult. Or it decreases by PaCO2. So just remember this concept that alveolar gas equation is talking to us regarding alveolar oxygen tension. The alveolar oxygen tension increases by FiO2 and decreases by PaCO2. Just for the concept. You all must have heard regarding alveolar arterial oxygen gradient, AA gradient. Technically it should be zero. Technically it should be zero. The same partial pressure of oxygen which is there in alveoli, we have the same partial pressure of oxygen in arterial blood. So the gradient is zero. So if the gradient is high, what does it mean? That means there is some pathology in the diffusion process. If this goes up, you're getting the point. See, this is alveolar side, this is arterial side. If the gradient is high, suppose here it is 100, here it is 60, the gradient is of 40. That means there is some pathology which is inhibiting this gas exchange at the alveolar basement membrane. If it is zero, that means everything has been exchanged. If it is zero, you have complete exchange of oxygen and that goes in equilibrium. So whenever there is some process which is causing restricted diffusion of oxygen, the gradient, AA gradient increase. See, gradient usually tells you that how faster the flow is. If you have a valvular lesion, high gradient means faster flow. You have a greater pressure difference. Here it is different. Here the gradient, if it is more, the pathology is more and exchange is less, right? AA gradient, it varies with age. So the formula is age divided by 4 plus 4. So if you are 40 years of age, 40 divided by 4 plus 4, so it is 14. So difference of gradient will be 14 millimeters of mercury. Okay, this is normal. As you grow older, your AA gradient widens. So what can be the cause of increased AA gradient? What can be the cause of increased AA gradient? The first and foremost would be anything which causes problem in your ventilation perfusion. So there is a mismatch of ventilation perfusion. Okay, you have large consolidation, pneumonia, wherein you have good perfusion but inadequate ventilation. So there is VQ mismatch. Then you have pulmonary embolism. Here you have good ventilation but there is inadequate perfusion. So again VQ mismatch. Okay. Then you have pulmonary edema and COPD. So these are the 4 important reasons where there is VQ mismatch, thereby causing increased AA gradient. Second would be shunting. Shunt will be present in congenital heart disease or AV malformations, pulmonary AV malformations. So they will cause shunting of blood. Again there will be AA gradient which will be widened. Third would be thickening of alveolar capillary membrane. Say for example, you have ILD, interstitial pulmonary fibrosis. There is thickening of alveolar basement membrane. Second would be pulmonary edema. Okay, last but not the least, there is destruction of alveolar capillary membrane. The membrane gets destroyed. So destruction is occurring in COPD. So these are the important cause of widened AA gradient. You have ventilation perfusion mismatch, wherein you have pneumonia, pulmonary embolism, pulmonary edema and COPD. You have shunting of blood, in which you have 2 causes, congenital heart disease and pulmonary AV malformations. You have thickening of alveolar capillary membrane which occurs in ILD and pulmonary edema, and you have destruction of alveolar capillary membrane which occurs in COPD. Okay, so this completes our today's lecture, in which we studied about 2 things. One was lung mechanics and other was gas exchange. Thank you so much.